Good afternoon, everyone, and welcome. Before we get started, I would like to highlight a few features of the Zoom webinar interface. First, the presentation slides are the main window, and the speakers will appear at the top just above the presentation. At the bottom of your screen is the Zoom menu bar. Here you'll find the Q&A box. We encourage you to use this feature to submit any questions at any point during the webinar. We will leave time for Q&A segment to address all questions at the end of the presentation. At the bottom of the menu, you'll also find a chat box. Please use this chat box to report any technical issues you may be experiencing. We will respond to those concerns as they come in. Another menu option is the raise hand icon. Please use this feature when you would like for us to unmute your line so that you can ask a question aloud during the Q&A segment. And at this time, I'd like to turn it over to Dr. Carroll.
Thank you, Brittany, and good afternoon, everyone. The Center of Medicare and Medicaid Services Division of Tribal Affairs, in collaboration with the CMS Clinical Standards Group, the Division of Outpatient Care in the Hospital and Ambulatory Policy Group, and Quality Measurement and Value-Based Incentive Group, welcome you to this All Tribes webinar on rural emergency hospitals as a new Medicare provider type, established by Section 125 of the Consolidated Appropriations Act. On December 27th, 2020, Congress enacted the Consolidated Appropriations Act, and Section 25 of the Act established a new provider type, the Rural Emergency Hospital, which is abbreviated REH. This summer, CMS published a proposed rule with request for information on the REH and to solicit comments to help inform policymaker decisions on the requirements for the REHs. Today, we'll discuss the statutory requirements and policy considerations for REHs related to the health and safety standards, payment, and quality measures and reporting. We are seeking input on any unique circumstances for Indian healthcare providers and communities with respect to this new provider type. I'd like to now turn the webinar over to Kiana Banks and Tamara Garcia from the Centers for Clinical Standards and Quality for further information on the Consolidated Appropriations Act and to lead the discussion on the rural emergency hospitals as they impact Indian healthcare providers and communities. Kiana, over to you.
Thank you so much, Dr. Carroll. We are very excited to be presenting this information on rural emergency hospitals to this group. I will just start with some brief introductions. We can move to the next slide. I'm Kiana Banks. I am a policy analyst or a health insurance specialist within the Center for Clinical Standards and Quality within their Clinical Standards Group. So the Clinical Standards Group is responsible for developing and maintaining and updating the health and safety standards, which we also call the conditions of participation, for those providers that are participating in Medicare and Medicaid. And those providers include hospitals, critical access hospitals, ambulatory surgery centers, certain types of health clinics and health centers, long-term care facilities, and now rural emergency hospitals. So that's sort of our role in the development of the requirements for rural emergency hospitals. And I'll just turn it over to Josh and then Tamara to provide a brief introduction as well.
Kiana, I am Josh McFeeters, and I'm a health insurance specialist in the Center for Medicare and in the Division of Outpatient Care. And our division will handle the payment policy issues related to the REHs as they are established.
Good afternoon, everyone. My name is Tamara Garcia. I am the Deputy Group Director of the Quality Measures and Value-Based Incentives Group. Our group houses approximately 20 quality payment programs. Some are pay for reporting, others are pay for performance. We are responsible for determining and defining, along with the Secretary's discretion, the measures that will be included in the quality measurement and quality reporting piece for the rural emergency hospitals. Thank you.
Thank you, Josh, and thank you, Tamara. So Josh will be presenting on the payment policy during this presentation, and then Tamara will be presenting on the policies related to quality measures and quality measures for rural emergency hospitals. Next slide. So just to give you a little bit of background, and I know Dr. Carroll provided some, I just wanted to talk about how this whole provider type came about. So there were growing concerns over the closures of rural hospitals and critical access hospitals in rural areas across the country. And with those closures came a lack of access to services. And one of those key services was emergency care. So following these concerns, Congress enacted Section 125 of the Consolidated Appropriations Act of 2021. We refer to that as the CAA or the statute, so you might hear that phrasing within this presentation. And that act established rural emergency hospitals as a new provider type. And just for your awareness, I provided the link in the presentation, and that will take you to the Consolidated Appropriations Act. Again, the rural emergency hospital requirements are in Section 125, and you can find those on page 1779 of that act. Next slide, please. So in accordance with the CAA, rural emergency hospitals have to convert from either a rural hospital with less than 50 beds or a critical access hospital. They must provide emergency services and they must furnish observation care. They may also provide other outpatient services as specified by the Secretary through rulemaking, and that's stated within the Consolidated Appropriations Act. And what that means is that the Secretary can determine what additional outpatient services rural emergency hospitals will be able to provide through our standard rulemaking process. Next slide, please. Also, in accordance with the statute, rural emergency hospitals may provide skilled nursing facility services and a distinct Part SNF. And what that means is that they can have a separately certified skilled nursing facility unit, and those units would be paid using like SNF payment requirements, and that's different from how the rural emergency hospital would be paid. And also the statute states that the rural emergency hospitals will be eligible for payment for items and services furnished on or after January 1st, 2023. Next slide. So we published a request for information, or an RFI, in the Outpatient and Ambulatory Surgical Center calendar year 2022 proposed rule earlier this year in August. The link is provided there for your reference as well. The purpose of publishing the RFI on rural emergency hospitals in that rule was to really obtain information from the public and stakeholders on things that we should be considering as we develop policies for this new provider type. The proposed policies for rural emergency hospitals, including the proposed conditions of participation, are currently under development, but they'll be developed through our standard rulemaking process, and I'll talk about that in a couple of slides. Next slide, please. So within the RFI, we had some targeted questions that focused on areas related to those health and safety standards that REHs should be required to comply with: payment policies, quality measures and quality reporting requirements, health equity, and then also any additional considerations and unintended consequences that should be taken into account as we develop the requirements for this new provider type. Next slide. So the comment period for that proposed rule, which includes this request for information, closed on September 17th. We received 54 public comments on the REH, the Rural Emergency Hospital Request for Information. And most of the comments, there was sort of a general consensus that stated that CMS should consider the challenges faced by providers of healthcare services in rural areas as we develop these requirements. And also folks generally felt that we should be pretty flexible in the requirements that we establish. And as far as the services that folks thought that rural emergency hospitals should be allowed to provide, those additional outpatient services, individuals felt that those should include maternal health services, telehealth services, behavioral health services, dental services, outpatient surgical services, and substance abuse services as well. There were also some comments related to payment policy and quality measures and quality reporting as well. Next slide. So as far as the health and safety standards or those conditions of participation are concerned for rural emergency hospitals, the Consolidated Appropriations Act requires that rural emergency hospitals be staffed 24/7 around the clock. A physician or one of the identified mid-level providers must be available to furnish rural emergency hospital services 24 hours a day. And rural emergency hospitals must meet the applicable critical access hospital staffing requirements that are listed in the conditions of participation. Next slide. The statute also requires that rural emergency hospitals have a transfer agreement with a level 1 or level 2 trauma center, that they meet those critical access hospital emergency services requirements within the critical access hospital conditions of participation. And it also states that they must meet the applicable hospital emergency department requirements. And just for your awareness, when we see things like the applicable hospital emergency department requirements, that just means that those requirements that we determine are applicable and appropriate for a rural emergency hospital. And again, all of these will be established via our standard rulemaking process. And also, rural emergency hospitals are subject to the Empower requirements in the Social Security Act. Next slide, please. And just for your awareness, this is not an exhaustive list of requirements that will be applicable to rural emergency hospitals. We just wanted to cover those requirements that are explicitly listed in the Consolidated Appropriations Act. And again, the Secretary has some discretion to include additional requirements. And those proposed conditions of participation or health and safety standards will be developed via our standard rulemaking process, which includes the publication of a notice of proposed rulemaking, which will then be followed by a comment period, and also followed by then a final rule containing the final provisions for rural emergency hospitals. Next slide, please. And now I will kick it over to Josh McFeeters to go over the payment policy.
Thank you, Kiana. So first of all, the payment policy, rural emergency hospitals will receive a 5% payment increase for those rural emergency hospital services, which Kiana discussed earlier. Those services are mostly emergency department services and observation care, and again, any other service that is defined through rulemaking by the Secretary. Next slide, please. There will also, REHs will also receive an additional facility payment. Now for 2023, which is the first year that REHs will be established, that facility payment will estimate the average facility payment for critical access hospitals from back in 2019. And then in subsequent years, that base facility payment that was calculated from the 2019 critical hospital data will be increased by the hospital market basket. One thing that's notable about the facility payment is that it'll be paid in equal monthly installments over the year. So every month there'll be 1/12 of that payment we made to the REH. REHs will also be required to maintain detailed information on how they use the facility payments they receive. Next slide. Now I'm going to turn it over to Tamara Garcia to discuss quality measures and quality reporting.
Thank you so much, Josh. So in addition to the conditions of participation and the larger payment policy, the CAA requires several activities around quality measures and reporting within the provision. Traditionally, quality measures are used to do several things. One, they promote higher quality and more efficient healthcare by creating an accountability structure. They also inform quality improvement practices within a facility or across a larger entity. So they give folks the information they need to figure out where to target care or improved practices. They also provide consumers with information that they need in order to make decisions about where they want to seek out care. And finally, last but not least, they tend to serve as an incentive when linked to payment or publicly reported. And so I think, it's essential to really kind of talk about what we are seeing within the CAA in terms of what they're mandating. So first, what's mandated within the CAA in the context of quality measures, rural emergency hospitals are required to submit data on a select few quality measures. Second, it signals that the measures for which data are to be submitted are selected at the Secretary's discretion. In other words, CMS, with, of course, departmental approval and after public comment, will define the measures and leverage the rulemaking process, of course, to formalize a policy around the measures that are required for reporting. Next, it signals that the data are to be publicly reported. With that being said, there are no payment-focused statute. There's no language associated with payment within the statute. So there's no link to payment for measure reporting or performance on the measures. Next slide. So there are several steps that we're really taking to implement this work. The first, which isn't mentioned here, of course, is close collaboration with our partners and the folks who have talked about the payment and the conditions of participation work today. Second, we are engaged in a lot of strategic planning for program implementation. So some of the activities that we consider essential to ensure successful launch are in engaging with the folks who will be required to submit data, being very clear about what those requirements will be, et cetera, et cetera. So we're kind of pulling all of that information together for future implementation. We're also doing environmental scans to determine sort of the most impactful, meaningful measures for the program, which again will be subject to public comment. So folks will have an opportunity to opine on those. We're also engaging in what we call pre-rulemaking activities. So in order to actually propose the measures in rulemaking, we go through a formal activity beforehand to ensure reliability, validity, et cetera, et cetera. And so the measures under consideration and something we leverage called the Measures Application Partnership, those will be the vehicles that allows experts to really sort of take a look at those measures before we even place them into rulemaking. And then of course, finally, rulemaking in a future outpatient prospective payment system rule, where those measures proposals will be submitted for public comment. Next slide. Next slide. So here we have the contact information for myself, Kiana, and Josh for your information. So please, if you have any questions, feel free to reach out. And I recognize that there may have been a duplicate slide. So the slide that preceded this really sort of breaks down those pieces of work, and we'll try to make sure folks get access to the slides as well. With that being said, I will turn it over to Brittany to open up the Q&A segment. Thank you.
Thank you, everyone. If you have any questions, please type those questions into the Q&A box or use the raise the hand feature, and we will give you access to unmute yourself so you can ask those questions live.
Hi, it's Dr. Carroll. I've noticed that the first question that comes to us from, I believe it's Kim Robinson, is just wondering if they can get a copy of these slides. The webinar itself is being recorded and it will be posted on the Division of Tribal Affairs website, which is at go.cms.gov/AIAN. And it takes a week or two to get the webinar recorded and posted. So within a couple of weeks, it should be available for review if anybody wants to relook at this presentation or listen further to the comments that we are looking forward to right now. Thanks.
Just remember to type those questions into the Q&A box at this time or use the raise the hand feature so that we can give you permission to unmute yourself so that you can ask your question verbally.
So this is Dr. Carroll. I'll start with a question that comes to my mind as I've listened to the presentation. There is, I think it was Kiana that said that there would be an annual payment for the rural emergency hospital. Do you have an idea of what that payment will be or what it is based on? Is it a user population number? Is it number of encounters? Or will it be just a general, you're a rural hospital, so you will get the following amount? Thanks.
I think I'm the best one who can answer that, Susan. So for that facility payment, what they're going to do is they're going to look back at how much was paid to critical access hospitals for their facility payment, make their best estimate back in 2019, and then get an average on how much that facility payment was for each critical access hospital. And that is the payment amount that will be the new facility payment. That's how it is determined. And again, that is for 2023. And then in subsequent years, it's going to be increased by the hospital market basket inflation measure.
We have another question. Would it be possible to type the website that the recording will be on into the chat box?
Yeah, yes, I'll do that.
Thank you, Dr. Carroll.
Brittany, can you read through Mr. Milholland's question, please?
Tribes are asking whether this is a viable option for them. Many tribal hospitals are not CAHs. Could you please provide a bit more information about the eligibility requirements for rural hospitals with fewer than 50 beds? What types of facilities meet this requirement? Are there any other requirements tribes should know about?
Hi, this is Kiana. So the requirements that are listed in the Consolidated Appropriations Act don't preclude a tribal hospital from converting to a rural emergency hospital if they are a critical access hospital or a rural hospital with less than 50 beds. So again, the requirement is that the facility be a rural hospital with less than 50 beds or a critical access hospital. I understand that there's concern about what a rural hospital with less than 50 beds actually means. That's spelled out within the Consolidated Appropriations Act, and there's some statutory references that are there, and we can provide that information. I don't have the specifics at this moment of exactly what the policies will be regarding exactly the types of facilities that will be able to convert, outside of the fact that there are these rural hospitals that have to meet these existing statutory requirements that are less than 50 beds. I'm not sure if Josh can speak more to that, because there may be some payment implications with that, but we can certainly provide the statutory reference for you.
Yeah, unfortunately, I don't have anything more to say on terms of the eligibility regarding that, but I think whatever Kiana sends along or the vision will be good.
And this is Dr. Carroll. I'll keep the questions going. I know that the tribes are sensitive to the fact that much of the quality data that they report in as Medicare and Medicaid hospitals is posted on, I believe it's cost compare and has been hospital compare. As you look forward to posting the data metrics and the outcomes, do you have an idea of where you might be posting it, or will it be separate? Any thoughts on how that posting will go? Thank you.
Sure. So of course, as we sort of implement, we'll have to have some discussions about the best place to post this. But nearly all of our programs that are publicly reported, especially the hospital stars, nursing home programs, they're all consolidated onto the Care Compare website that was launched last year. And so I envision that we will take the same approach here. I would also note that we tend to have small facility adjustments in some cases. In that case, of course, there would be some situations where we would suppress data in some cases where there's not enough information in order to display the data. It may be impacted by the power. A small n. And so want folks to take that into consideration as well. That's typically noted, but that's exactly where we would post it on the Care Compare website.
Thank you.
Okay, we had another question coming. Is there a projection of how many facilities nationwide that will transition to this provider type? And then can a hospital be CAH, REH, and also participate in PCMH? Our hospital is already CAH with plans to implement PCMH soon. How will REH affect our facility?
So just to address the first part of the question regarding the numbers of facilities, there was a study that is public information, and we can provide that information to the folks on this call that I think it was University of North Carolina conducted, or one of their research centers conducted, to really do an analysis of which facilities would be eligible. And they came up with, I believe it was about 60 or 64 facilities, if I'm not mistaken, as far as the number of facilities that would be eligible. Now, that doesn't mean that all of those facilities will convert, but that just means that based on the analysis done by this outside entity conducted, found that there would be about 64 facilities that would be eligible to convert. And then the second question was, I'm not sure if the ask is whether or not you can be a critical access hospital and a rural emergency hospital and a PCMH simultaneously. If that's the question, and I'm not sure what a PCMH is, but you cannot be certified as through Medicare as both a critical access hospital and a rural emergency hospital. So you would have to be either one or the other to participate in Medicare. So if the facility is a critical access hospital and they wanted to convert to a rural emergency hospital, they would be able to do that, in essence, becoming a rural emergency hospital, and then no longer functioning as a critical access hospital or receiving payment as a critical access hospital.
So Kiana, it's Dr. Carroll. The PCMH is a patient-centered medical home. It's an accreditation that happens through, I believe it's the Joint Commission or AAAHC. And many of the tribal and Indian Health Service hospitals have been working towards patient-centered medical home. So that's why I'm not sure what the answer is as it reflects into a rural emergency hospital. But it's something that we could think about, and it would be good as we move forward with the rulemaking to consider that concept, which is a good quality concept for what the hospitals are doing, to see whether it would extend over to a rural emergency hospital.
Right, and also, if I'm hearing you correctly, it's a Joint Commission accreditation program, so it would also be up to the Joint Commission if they were to extend that to rural emergency hospitals. And that's sort of outside of our purview. That would be up to the Joint Commission.
Very good, thank you.
Type those questions in the Q&A box for us, or click on the raise the hand feature so that we can allow you to unmute yourself so you can ask those questions live.
Okay, I'll ask another question. This is Dr. Carroll again. You have already put out the request for information. When would we be looking for the next proposed rule to come out with further information on these hospital types?
So as far as the schedule for the proposed health and safety standards and policies, or i.e. the conditions of participation, that is forthcoming at some point in 2022. And then again, there will be a public comment period, and also there will be a subsequent final rule in time for folks to be able to receive payment for items and services furnished on or after January 1, 2023.
Thank you.
Place your questions in the Q&A box or use the raise your hand feature so that we can allow you permission to unmute yourself to ask your question live. I'm not seeing anything come through or any hands being raised. Kiana, do you and the panelists have any closing remarks?
Again, I just wanted to thank the Division of Tribal Affairs for helping pull this presentation together to provide us with the opportunity to present this information to the tribal community. And, you know, we look forward to putting out our proposed rule and getting robust comments on those proposed policies so that we can come out with final policies that are beneficial to all those that plan on participating in the Rural Emergency Hospital Program.
And I'd like to thank Kiana, Tamara, and Joshua for a great presentation. Really appreciate. I know it took a lot of work to get this together, and we look forward to the next proposed rule. If anybody has any further questions, there is the Tribal Affairs mailbox, which is at tribalaffairs@cms.hhs.gov. We're more than happy to field those questions, get them up to Kiana and her team, and happy to get more information out to you as this exciting new provider type moves forward. You see, we might have a couple more questions. Brittany?
Tribal hospitals currently bill Medicare at tribal rates set out by Office of Management and Budget annually in the Federal Register. Would they be able to bill at the same rates if they were to convert to a REH?
I have to defer to Josh on that one.
Yeah, I can't speak to that. I mean, maybe we can look into that further. I saw someone else may want to answer it live, but if not, we can research it and get back to you.
And then the second question that came in is there a process to establish a new REH? What would the additional facility payments be calculated on if it is a new facility?
I'm sorry, I was trying to find the question. I thought I saw it. Can you just repeat the question, Brittany? I don't see it in the chat box for some reason.
Is there a
I see it.
process?
It wasn't in- I see it.
Is there a process to
So-
establish a new REH? What would the additional facility payments be calculated on if it's a new facility?
So there will be a process similar to the process for critical access hospitals and hospitals that are coming into the Medicare program and applying to that. That is currently under development, and what those policies will look like. I can say that it will be similar to how those facilities come into the program or convert from, let's say, how a critical access hospital converts from a hospital. It'll be similar to that, not saying that it'll be identical to that, but that process also is still under development.
In regards to the payments, again, this what the statute says to get an average payment for each REH facility. So an average will be made up, and it should. We'll look into it, but I think the following statute, I think it has applied equally. There's not like a set pot that's going to be lowered or raised. I think based on the statute, it looks like payments are going to be equivalent for providers. But again, we'll provide more information in our upcoming rules that we write, or RFIs, about this about the REHs.
For additional questions, please type those questions into the Q&A box now or use the raise the hand feature. Okay. Are there any additional closing remarks from the panelists?
I don't have any, thank you.
Okay.
Well, I want to thank everyone for taking the time today to join us to to learn about rural emergency hospitals, an exciting new provider type, and I'm looking forward to working with the team as they put together their next proposed rule. And please do think about this new option across the country for IHS and tribal hospitals, as rural healthcare is a priority for CMS. So we thank you, and I wish everyone a great afternoon. Take care.